say welcome to those of you for you who are joining us for this, I think, an important discussion and dialogue. And we're certainly honored to have Dr. Alcena as our facilitator for the meeting tonight. But let me tell you one thing, because I'm a worrier, and I always worry about the size of the crowd and everything, but I'm also a professor at Manhattanville College, and I tell them I'll teach one. So if we get the word out one by one, two by two, whatever, it is certainly worth our time and effort, and especially in the context of educating and sharing information to our various publics. I am a member of the African American Men of Westchester. This is our second, and for those who were with us last year, it was specifically September 24th, I ended the meeting by saying, to be continued. And so this is the continuation of a commitment that we made some time ago as part of our health initiatives and education committee. I am the chair of the education committee. I'm joined by the chair of our health committee, Hassan Belisle, and certainly he has been a big help in putting the word out and publicizing this, but also participating with the effort that we have. So I appreciate your being here, and would like to get started. As an acknowledgement, before we get into the formal part of the program, I have to acknowledge Judith Watson. Judith, please.
Good evening, everyone. Thank you all for showing up. Let me say this. Welcome to the Greenberg House Center. As a matter of housekeeping, the restrooms are to your rear on the right. And we have collaborated with the African American Men of Westchester for over 16 years. Right, Mac?
About, 16, 17 years.
We collaborate on an annual health fair, and so we're delighted that you all decided to host this event here tonight at Greenberg Health Center, so thank you very much. And the fact that Dr. Alcena, one of my favorite people on earth, one of the smartest doctors in the United States, is going to be facilitating tonight, so I'm super excited, and that's all I have to say. Enjoy it.
Thank you, Judith. I have the honor of introducing Dr. Alcena using his resume. It's over here, but I've got the art and practice of modern clinical medicine, but I'm going to use the short version with your permission. Dr. Valiere Alcena arrived in the United States as an orphan runaway from Haiti, without an education, but worked diligently cleaning restrooms, labored in a factory, and pushed carts in New York's garment district before obtaining his elementary school diploma. After passing the entrance exam to Hunter College, he took day classes while completing requirements for his high school diploma. He transferred to Queens College after being denied entrance into the medical program at Hunter because of his color, and in 1973 received his medical degree from Albert Einstein College of Medicine of Yeshiva University, where he later became professor. Today, Dr. Alcena is a world-renowned oncologist and a hematologist, and has been an attending physician at several hospitals, including White Plains Hospital and Montefiore Medical Center, where he has practiced for over 18 years, in addition to having his own private practice. Dr. Alcena has made many major discoveries and published several ideas that have contributed significantly to the field of medicine in the 20th and 21st centuries. He is the first person to propose the idea that male circumcision could decrease the incidence of HIV and AIDS, resulting in millions of lives being saved. In 2007, Time magazine also credited, in 2007, Time magazine named Dr. Alcena's idea #1 among the top 10 medical breakthroughs in the world. Dr. Alcena is also credited with proposing the establishment of community health centers in underserved neighborhoods throughout the United States while he was a medical student in 1970. In addition to his career as physician, Dr. Alcena is a TV producer, host, and author of several books. He's the founder, president, and publisher of NEGRE Publishing Company, founder of Alcena Africa Hunger Relief Fund, president and CEO of Alcena Medical Communications, founder and chairman of White Plains Community Health Fair, Inc., among other distinctions. He holds esteemed memberships including the Royal Society of Medicine, lifetime member of the Westchester Medical Society, Greater New York Sickle Cell Foundation, and the National Medical Association. Dr. Alcena has received countless honors, including Best Doctor in the New York metro area, one of America's top physicians by the Consumer Research Council of America, Lifetime Achievement Award presented by the Albert Einstein College of Medicine, President Bush's Volunteer Award, New York State Commendation for Community Work, Senate Commendation for Community Work. On May 15, 2008, Dr. Alcena was inducted into the American College of Physicians as a Master of the American College of Physicians. Please join me in welcoming Dr. Valiere Alcena.
Thank you. Thank you so much. I'd like to thank, of course, Ms. Watson for having me here tonight, and of course, Mr. Bowman for your gracious introduction. I am here to talk a little bit about sickle cell anemia. Chapter 65 of this big book, 136 chapter of it, is on sickle cell anemia. I'm going to pass this around because since I don't have a way to show it so that you could see what a sickle cell actually looks like. Very important that you see that. See what a sickle cell actually looks like. And what is a sickle cell? Well, a sickle cell is a red blood cell that is malformed, and the malformation results in the cell becoming banana shaped. In addition to becoming banana shaped, the cell is very, very sticky. It has difficulty passing through blood vessel. That difficulty in turn results in a multitude of complications that I'm going to talk to you about and the people who are unfortunately afflicted by it. Historically, the first case of sickle cell disease known to mankind was actually discovered in the year, believe it or not, 1670. That far back. That was in the Ghanaian family in Africa. That was 1670. This is how far back as that go. In this country, however, sickle cell disease was first discovered by a Dr. James Herrick, James Bryan Herrick, and Dr. Ernest Irons in Chicago, and a young dental student by the name of Walter Clement Noel from the island of Grenada in the Caribbean. He got very sick, and they couldn't figure out what was wrong with him, and these doctors were smart enough to decide to take a look at his blood smear under the microscope. That's the first time sickle cell disease was discovered in this country and North America, period. You need to know that the percentage of folks with sickle cell trait is 8.5% in both Latinos and blacks in this country. The same, 8.5, okay? Now, totally, you have 3,600,000 folks in this country who carry the sickle cell AC, the trait. And altogether, 100,000 folk carry sickle cell disease that had the full-blown disease. Now you have 3 separate genes that causes sickle cell anemia, and I'll name them to you, okay? BEN stands for the Republic of Benin, that's where that came from. CAR, Central African Republic, and SEN stand for Senegal. These are the 3 separate individual genes that can cause sickle cell anemia. And depending on which slave boat came from which part of Africa, we wind up having either somebody with sickle cell disease, either the band, the sand, or the car, okay? Doesn't really matter. The devastation is the same, okay? Now, what happens is that when you have sickle cell disease, every single part of your body, from your hair down to your toenail, get affected by sickle cell because it goes throughout. Wherever blood goes, the sickle cell go, and it has trouble going through the vessel, and you have the problems. Now, we have different sickle cell crises. We have the hemolytic crisis, we have the painful crisis, we have the hypoplastic crisis, when we have a acute chest syndrome, then we have the what's called splenic sequestration. That is seen mostly in neonatal, because the splenic sequestration is when an infant who has sickle cell, out of the blue, for a reason that's not known to us, the entire volume of his or blood shifted to the spleen, and the baby goes into shock. That must be recognized immediately, otherwise you lose the baby. Okay, so that's called splenic sequestration. Now, before we get to that point, however, I must tell you that how this was discovered. Well, Dr. Linus Pauling in this country discovered the abnormality that causes sickle cell disease, which is basically in the position 6 of the beta chain of the hemoglobin. He discovered there's a substitution from a chemical material called valine for glutamic acid. That's it. That simple substitution. That's the reason for sickle cell anemia. Now, as bad a disease as sickle cell anemia is, credit to that disease. That disease resulted in everything that's happening in modern medicine, because this was the first time, as the gentleman is a biochemist, this was the first time, Mr. Bowman will tell you, that the concept of chemistry changed for everything. Pharmacology, genetics, all the DNA stuff you heard about. None of this thing would have been possible if this discovery was not made by Dr. Linus Pauling. For that, he got the Nobel Prize. And the entire evolution, every medication we're taking, all the tests that we do, the entire field of pharmacology, everything, that was the first test in chemistry that resulted, that opened up the world that we know it today, that all of us have to deal with, right or wrong, okay? So now that I get that out of the way, let's not waste much time and talk to you a little bit about the genetics of it. It's quite complicated. It's very complicated. I'll try to explain it to you the best I can, that you understand how one parent can transmit the gene to another. That's very important, because you have to understand that if an individual with no abnormal hemoglobin is born with 98% hemoglobin A and 2% of hemoglobin 2, that is A2. A1, 98%, A2 is 2%. Now, when you have sickle cell disease, when you have sickle cell trait, between 35% or 40% of your hemoglobins are sickle, and 65 to 70% are normal. When you have sickle cell disease, it's the reverse, the absolute reverse. 70% sickle cell, 30% normal, which means that 70% of your cells are useless to you. All they can do is cause you problem, and they do. And you are surviving only on 30% normal red blood cell. However, every now and again, when two folks get together, they decide to have a baby, if one is carrying the AS and the other one is also carrying the AS, the two AS get together and they have a child, and I'll try to read these things. It's a bit complicated. I'll try to simplify it, okay? So when you have two heterozygotes getting together to have a child, what's going to happen is that 25% is likely to have sickle cell disease, and 25% is likely to have sickle cell trait, and 50% will be normal, okay? Now, if both of them have SS and they decide to have children, 100% of the children will have sickle cell disease. Now, on the other hand, if they run across someone who has sickle cells, who has hemoglobin C, and either the person has SS or SA, they decide to have a child, then the C and the S get together and you have hemoglobin SC. So you have, therefore, 4 separate abnormal sickle cell syndrome: AC, SS, SC, and sickle thalassemia. So you can't talk about just sickle cell disease without talking about the other hemoglobin, because you have hemoglobin SC, you got hemoglobin beta thalassemia, together with an S, you got sickle cell, you got beta thalassemia connected with with the hemoglobin S. So those 4 things must be kept in mind because they behave differently. Believe me, if you have SC, you're likely to have terrible problem with your eyes throughout life. Don't ask me why, but you have more problem with your eyes with SC than you have with SS, and so on and so forth. And then you have hemoglobin SS, you have no spleen. Since infancy, your spleen has been knocked out, so you have no spleen, which predisposes you more to infection and so on and so forth. Now, if you have sickle beta thalassemia, you have a spleen. And clinically, as Dr. Davis will tell you, that has big importance. And also, if you have SC, you have a spleen too. Well, when you come in with sepulchral crisis, you're having crisis, you have a pain in the belly. If you have SS, I don't have to worry about you rupturing your spleen because you don't have a spleen. But if you come with SC and all of a sudden you bending down in pain, I have to keep in my front of my head to do a CAT scan right away because you may have ruptured that spleen. You understand? The same with beta, okay? Now, what are the folks in the world who are affected with sickle cell disease? Don't think for a minute it's just black folks. I just told you, Latino also 8.5%. Now, you got the Mediterranean folks, you got the Italian folks who are from Naples and also from Sicily, because they're immediately from North Africa. So you have a whole lot of folks. You have, for instance, you can't make this up, there are more sickle cell disease in India than there are in this country. Absolutely. Let me repeat that. You have more people with sickle cell disease on sickle cell in India than you have here, because you have more folks in India, 1.5 billion or whatever, okay? And there's a whole section of India where folks have sickle cell. They don't talk about it. And then in the Arabic Peninsula as well, you have, they don't want to call it, they don't want to talk about it, but they spend billions of dollars trying to call it something else, but it is in fact sickle cell disease, okay? Okay, so in the entire Arabic Peninsula, you have people who actually have sickle cell disease. Now, because of that, you wind up having to prophylax individual. If someone has sickle cell disease, they must receive the pneumovax every 3 years. Someone has sickle cell disease, it doesn't matter whether it's SC, sickle thal or whatever, you must put them on penicillin. If they are allergic to penicillin, you must give them erythromycin every day. And the reason for that is that when you have sickle cell, you don't have a spleen, all the bacteria organisms that have a capsule is going to knock you out. Why? Because the spleen produces certain things, enzymes that are there to really get rid of the capsule of the bacteria, but you don't have a spleen. So that's why we give pneumovax, because the pneumovax is against pneumococci pneumonia organism and so on. So that's the reason for it, okay? Now let's talk a little bit about the crisis. It's very important, because the bottom line is people come to the hospital. You have to understand, sickle cell disease patient gets sick from infancy. They're in and out of the clinic, in and out of the hospital, and they wind up having to be admitted with pneumonia, urinary tract infection, and so on and so forth, and severe pain. So you have, they hemolyze. Out of the blue, they can hemolyze. For no reason at all, suddenly they hemolyze. And I'll show you how to handle that. Then suddenly, these people show up, they're in severe pain. What's the result of the pain? Well, every one of us here, at one time when we stub our fingers, right? We develop a blister, right? There's a watery material in the blister, right? You know what that is? That's called kinin. That's, if you burst the blister right away, it burns like crazy, right? But that's what happens when you have ischemia, because the blood cannot get through, it gets stuck. Oxygen cannot be delivered to that tissue. The tissue becomes ischemic. That ischemic area releases kinin, the kinin causes the pain. Now you know why people who have sickle cell disease have severe pain, because the red blood cell cannot get through, they get stuck. The stuff that I pass around to the normal red cell that people have is able to squeeze through every little vessel. Even the vessel at the tip of my finger has red blood cell in it. It can get there. But when you have sickle cell in your system, the cell is very thick, it gets stuck. Not only that, you probably didn't know that before, sickle cell disease is also an inflammatory disease. Well, how does it become an inflammatory disease? Well, when the cell gets stuck in the vessel, the cell-to-vessel reaction creates a local inflammation. Okay, local inflammation. That local inflammation, there's two things. It causes an inflammation, which causes an inflammation. It can also cause plaque. When every time a vessel is inflamed, that vessel is going to develop plaque, causing more and more narrowing, okay? That is why when we're treating people with sickle cell disease, if there is no contraindication, we'll give them aspirin, 1 aspirin a day, or we give them Motrin or whatever. We do that for that reason, because it's also an inflammatory disease, okay? Now, we have shown, even in infancy, even when the baby is in the mother's womb, we can show that the brain is getting damaged because cells getting stuck inside the brain, okay? And then, of course, all vessels, you cannot have sickle cell disease and live long enough, don't have kidney problem, okay? Now, I told you about the crises, hemolytic crisis, painful crisis, hypoplastic crisis, acute chest syndrome crisis, priapism, and bleed. Well, why do people with sickle cell bleed from the urine? I'll tell you why. Well, and known to all of you, except probably Dr. Davis and other doctors, all of us, our left kidney is higher than the right kidney. That's how God made us, right? Our left kidney is positioned higher than the right kidney. What's the meaning of that? Well, there's a series of stuff in the kidney called papillae. The papillae need blood, you know, so the blood cannot reach the papillae. So you got papillary necrosis. Every time you see a sickler is bleeding from his or her urine, he or she is having papillary necrosis because oxygen could not get to that part of the kidney. That then become necrosed and they bleed like crazy, okay? And I want you to understand, having AS is not a bargain, because AS has its own problem. Each one of these syndrome has their own profile of abnormalities. For instance, very important in black men and black women for that matter, who are going to join the military. How about that? Now we just found out, now they develop rhabdomyolysis. What is rhabdomyolysis? Well, rhabdomyolysis, when you have sickle cell trait, because they won't take you if you have sickle cell disease. If you have sickle cell trait, they take you under intense exercise, which you have to do in the army or wherever it is you are. What's happened? You develop muscle breakdown, which knock down your kidney. You could go on acute kidney failure. How about that? That's a rhabdomyolysis from having sickle cell trait. And sickle cell trait also causes severe arthritis, osteoarthritis. Sickle cell disease, sickle cell trait prevents you from concentrating your urine properly. I can go on and on. So just because you have sickle cell trait doesn't mean you're free. You have a lot of problem as well. So let's go over the crisis. Okay, hemolytic crisis. You start hemolyzing, we have to treat you. The best treatment for hemolytic crisis is blood transfusion. That's right, blood transfusion. Well, you give blood transfusion, what happened? Well, you keep giving blood transfusion, you go wind up with a bunch of iron in your system, okay? So you develop secondary hemochromatosis, which by itself is a major problem. How did it get to major? Well, whenever the iron piles up, the iron by necessity must degrade. As the iron is degrading, it's releasing free radical, damaging your vessel. So you have a double whammy, okay? You need the blood, but when you get too much of it, that's what happened. So now what we like to do, in academic medicine anyway, we have to fight the insurance companies, we give you Epogen. We give you Epogen or Procreate, which I'm sure all the sticklers will tell you usually get. That mobilizes the iron. So you use the iron to make red cell while you're removing it at the same time. So that's one way to deal with it. But the worst form of crisis, of course, are the painful crises. Not the most lethal, but the worst form. Why is it terrible? I'm telling you, if you see people in the fetal position when they're in pain, it is terrible to see. But as doctors, the pain is severe. So what you have to do, you have to treat them. The worst medication you could give a sickler is Demerol. Why? It is the worst medication. Why? Because the Demerol is very addictive and it doesn't do anything because the Demerol itself doesn't do the job. It's the breakdown of the Demerol that does the job, and it is very toxic. It causes seizure. Thank you very much. See, it causes seizure. However, the patient needs medication. She's not an addict. She's got a disease. The best medication is Dilaudid or morphine. Dilaudid or morphine, not Demerol. The Demerol is just going to be addicted, and it's no good. It's not going to do anything for you. So that's the painful crisis. And when you're being treated for the pain, treat the patient adequately for the pain. He or she is really in pain. Is really in pain. So big deal. She's been in pain since she was a baby, so she's addicted to it. So what you going to do? Let her suffer? So you give her the pain medication, okay? And then you have to know what to do, otherwise give oxygen, etc., a lot of fluid, a lot of blood to provide new red blood cells so that she's got more oxygen to alleviate the pain. You do that, okay? Now, the most dangerous, one of the two most dangerous crises, it turns out is hypoplastic crisis. What is that? That is when the bone marrow is shut down because of an infection, a viral infection. Parvovirus is a classic example. So when somebody comes in, you're better off to see them have hemolyzing than if they're not. Because they're in more trouble if they're not hemolyzing, if the bone marrow is shut down. So when the patient shows up, one of the key tests that you do, besides checking the red blood cell, is a reticulocyte count. So the higher the level of baby red cell, the better shape the person is in. Okay? If they have a low reticulocyte, you do a whole lot of trouble. That's called hypoplastic crisis. Now, the most dangerous crisis is the acute chest syndrome. What that is that something is happening because hypoxia, fat embolism, or God knows what, and this individual secrete a bunch of terrible things, and their lungs become stiff, oxygen cannot be moved around, and the patient is about to die. And if you miss that, you have a dead patient. But if you're smart enough to recognize, because the chest x-ray is going to look like you have pneumonia, it's going to be all white. You got to be able to use other material, which I wouldn't talk to you about, because there's 17 pages here, you could read that, because I don't want to teach you everything I know. So you have to be smart enough to figure out you're dealing with the acute chest syndrome. You have hours before the patient is dead. So you have to move fast and go right ahead and recognize it, know what blood tests to do to document it, oxygenate the patient, intubate the patient, give her enough oxygen, and you give the claim that there's some mycoplasma organism is involved, so you treat them for mycoplasma, whether they have it or not, you don't want to get the chance. You give them erythromycin, which is good for mycoplasma, blah, 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 and so on. But it's a real crisis, because if you miss that diagnosis during the night, by the next morning you have a dead patient, okay? So, and then of course, the other crisis, you could have a combination of things going on at the same time. Sickle crisis, painful crisis, acute chest syndrome, hypoplastic crisis, and a sickler, anything can be going on simultaneously. So it takes years of experience to be able to figure out, and knowing the patient, knowing your patient, you know exactly what's going on with this patient. She's not faking it, she's really sick, and then you will be able to figure it out. So those are the different crises. Now let's talk about treatment. We talk about red blood cell is key. Well, there's more to treatment than that. Folic acid is important. Why is folic acid so important? Well, everyone who's hemolyzing is automatically using folic acid to make new red blood cell by necessity. So everybody who is hemolyzing by definition is folic acid deficient. Everybody who's hemolyzing is folate deficient. So giving somebody 1 milligram of folic acid is useless. It does nothing. 1 milligram does nothing for you. So basically, you need tremendous amount of folic acid, because when you are hemolyzing, you need somewhere between 2 or 6 milligram of folic acid, sometimes 8 or 10 milligram. As a matter of fact, the recommended dose of folic acid is a maximum of 25 milligram. The pharmacists go crazy when they see that. The point is, you don't 1 milligram is only good for nutritional purposes. My patients are getting an average of 8 milligrams per day. And you don't want to be without folic acid, because if you do, you wind up with hypoplastic crisis. You don't need that. So you get as much folic acid as you can. So that's a key point to remember. And of course, you have to hydrate the patient properly, make sure the patient is well oxygenated, and you give them folic acid. But in addition to the folic acid, there's something else going on. There's something called hydroxyurea. Now we're really moving into academia now. What is hydroxyurea? Hydroxyurea is a medication used throughout the world to treat a condition called polycythemia vera. But we're smart enough to have figured out that hydroxyurea causes all of us adults, believe it or not, still capable of producing fetal hemoglobin. How about that? We are all able to produce fetal hemoglobin. Our liver is still capable of doing that. So what the hydroxyurea is, it stimulates the production of fetal hemoglobin from the liver, and because the body is fantastic in using fetal hemoglobin. No problem. Fetal hemoglobin, the body loves it. That is the reason why we use hydroxyurea to stimulate the production of fetal hemoglobin that then makes you better. You got to understand something. Fetal hemoglobin is very important. Very important, fetal hemoglobin is. Very, very important, fetal hemoglobin. By getting hydroxyurea, you were able to produce enough of the fetal hemoglobin. You have to understand, sickle cell anemia is not the most common hereditary abnormality in black. You know which is the most common? Alpha thalassemia. That's right. 32% of black folks carry alpha thalassemia. 2% are missing 2 chains, okay? 30% are missing 1 chain. Now, why is that important? Well, guess what? People who have sickle cell anemia are also carrying the alpha thalassemia. The alpha thalassemia modifies the severity of the sickle cell disease. That's why you see some folks who have sickle cell disease get less sick than others. I bet you if you test them for alpha, they have alpha. And the alpha modifies the severity of the disease, 30%. If you didn't know before, the #1 hereditary abnormality in black folks in the world is alpha thalassemia. It's not sickle cell. Even though you have 300 million folks carry the sickle cell gene worldwide, and in Nigeria alone, 4 million people have sickle cell anemia. So it's a very common disease. Worldwide, 300 million carry that abnormality. And then in Nigeria, it's a devastation, okay? So you have to understand that when you're talking about hereditary abnormality, you just learn the most common. The reason why you don't hear much about it, and I'll tell it to you, I don't have the blackboard to show you, but I'll show you, okay? When it's to understand how powerful God really is, and we know that to begin with. When you have alpha thalassemia, and you have the 2%, the 2 alpha chain that you are missing, they are on opposite side of the equation. One to the right, one to the left. How about that? However, the same disease, if you are Southeast Asia, you're missing both chain, both to the same side. That's called hemoglobin constant spring. It is so bad, it's a public health menace in that part of the world. But in us black folks, God decided to do it, but do it on each side of and we don't get sick. How about that? The person who's missing 1 chain, you're not even anemic. The person that's missing 2 chains on either side is a little bit anemic. Why is that important? That's very important because when you go to doctors, us people, even though we don't always do the care that we need, your red blood cell count is going to look strange. It's going to look strange. Your MCV will be low. So if the doctor is not up to snuff, he or she is going to do a lot of wasteful tests thinking that you're bleeding somewhere, that's why your MCV is low. It's not. If she's smart enough or he's smart enough, take a look at the red blood cell. Let me tell you the equation. The only equation that exists in the field of medicine is that for every 10%, you got to write this down, for every 10% of your hematocrit is equal to 1 million of your red blood cell. So therefore, take a look at a glance. You could look at the sheet in your hand. If look at the equation. If you have 1 million red blood cell, or let's say you have 3 million red blood cell, you should have 30% hematocrit. But how come you wind up with 30% hematocrit and 6 million red blood cells? That's exactly what you're going to look like if you have alpha thalassemia, beta thalassemia, or hemoglobin C. Right away, that should trigger, that's called erythrocytosis with microcytosis. It saves you thousands of wasteful dollars by just knowing that formula. And anything above 500,000, that's erythrocytosis with microcytosis. And if you take an exam, your board exam, I know I used to be an examiner for the board, you're going to see that on the exam. You're going to see that. They're going to show you. Erythrocyte, and then they get to do what test to do next. You do a quantitative hemoglobin erythrophoresis. When you do a quantitative hemoglobin, not qualitative, quantitative hemoglobin, that's going to show you what percent of abnormal hemoglobin you're actually carrying. And if you have that abnormality in your hemoglobin, in your CBC paper, and the hemoglobin erythrophoresis is normal, you know what that is? That's alpha thalassemia by the process of elimination. Let me repeat that. If you see that characteristic in your CBC that we get from the computer, Dr. Davis and the other doctor, when you see that, and you look left, you look right, you order the hemoglobin erythrophoresis, if it comes back normal, you just diagnose alpha thalassemia. How about that? And that saves you thousands of dollars of doing this colonoscopy, this and that and that and that, when in fact you have a erythrocyte. You understand what I'm saying? So you have to understand medicine to practice it, okay? So sickle cell anemia is not just standing by itself. The same thing happened. If you have sickle C, you got sickle beta thalassemia, you're going to see erythrocytosis with microcytosis because of the C hemoglobin, which is, by the way, come from West Africa. Everybody with C hemoglobin come from West Africa. And you're going to automatically see that your MCV, mean corpuscular volume, is going to be low, not because you're bleeding. You may be bleeding, but we have other ways of telling. I'm not going to tell you, but we have other ways of telling if you're bleeding and still have these things. I know. But suffice it to say, take a look every time you're looking at the blood count result. Don't just tell me about your hematocrit. Tell me what the red blood cell is as well. Then you know if it matches. If it doesn't match, there's a discordance, you have an abnormal hemoglobin. And that's exactly what they're going to do to you when they give you an exam for your board. They're going to show you that, and they're going to do what do you do next. And then you do next, you do a quantitative hemoglobinophoresis, and then you got the answer right there, you move. You get that one right. You move to the next one, okay? So in any event, I can now take some questions. What else do I have? Have I left anything out?
I think you did pretty good there, Dr.
I think I did pretty good there? Okay, so I can ask some questions. I can answer some questions for you. Yes.
As a matter of fact, too, there are some index cards, so if you've got a question and you fear you're going to forget it before we get around to you, write it down so they're on each row.
Mm-hmm. Oh, yeah, I did, one more thing, please. I didn't talk about transplantation. I didn't talk about stem cell transplantation. There have been some success stories across the world, and also pneumovax, blah, 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 blah. They're now doing bone marrow transplant. They're also doing stem cell transplantation. There's been some significant successes throughout the world. I just wanted to mention that. Go ahead.
Dr. Alcena,
Yeah.
what causes the change in the genetic code which causes the mutation? Now, the mutation, again, obviously results in the shape of the red blood cell.
Yes.
But the genetic code is really the trigger.
Yeah, the trigger is when the mother or the father, vice versa, is carrying the gene, and the two of them that together to have a baby, and then that's when you have the gene transfer, which then lead to the abnormal transfer in the hemoglobin at the position 6. The abnormality is really the change from valine to glutamic acid as position 6 of the hemoglobin chain. That's the abnormality. That's the gene. That's what causes that. That's where the abnormality begins right there. In other words, you have normal hemoglobin, the position 6, valine should be over there, glutamic should be here, but there's a switch.
But I guess in our development,
Right.
what would have caused that? And I know that's the result of it, but would it have been the result of a virus or something?
No,
Bad
it's
water or something?
No,
as we evolved?
no, we evolved that way. See, we evolved this, let me tell you something. Okay, now you're taking me to another point. Here's what happened. I know what Mark is getting to. It is said, right, wrong or right, that the human race, as we know it in the modern world, wouldn't exist were it not for the fact that God, for whatever reason and its power, decided to create sickle cell anemia. Why is that? Well, it turns out that the malaria cells would have wiped out, the malaria would have wiped out the human race, would have wiped us out. We wouldn't exist. Because the sickle cell is abnormal, malaria cannot survive in it. And because of that, some of us survive. And it is the some of us that survive that subsequently give, no matter what the Trump people are saying in politics, life began in Africa. And this is all of us. And by the way, in case you didn't know, the gene for intelligence began in Africa as well. And as a matter of fact, Africa had universities before Europeans knew what university was, and even how to spell university. So, you understand that? Okay. So therefore, then, the human race, as we know it, that's why I can't live in the South, because I have to tell the truth. They'll kill me in a minute. The point is, that's exactly what happened. The world as we know it wouldn't exist were it not for the fact that the sickle cell anemia, those people who survived because the malaria couldn't survive within that cell. Whether that's true or not, that's the theory. Some religious people also said it, which means there may be some truth to it. Who's to question God? And who's to question religious people? And this has been going on for centuries. And apparently there must be some truth to it, because there's no way malaria can survive in those cells that are sickling. So therefore, these people survive, and it is those people, the remnants of those people, that subsequently gave birth to the rest of the world. Okay? Okay? So, as bad a disease as sickle cell is, it's responsible in some way to us being here. It's also responsible for entire modern medicine. Absolutely, there's nothing that's happening in modern medicine that's not the result of that research that Dr. Linus Pauling did. That's it. Entire molecular biology, molecular pharmacology, molecular everything you want to call it, all the DNA stuff you talk about, all because of that singular original research. Okay? Anything else? Yes.
Dr. Alcena, you mentioned about the stem cell.
Yes.
And there's been some success
Yes.
with stem cell.
Right.
So is this being explored on a major scale?
Yeah,
Or
yes.
where are we now with that?
Yes, it is, because there's been funding provided recently from the NIH to the folks who are involved in multiple universities in this country and across the world that are doing research to expand it. There's been some significant success involving stem cell transplantation. There's been a lot of people alive with no trace of sickling in the system whatsoever. There have been some bone marrow transplant. That's been a little bit more problematic because of rejection. There's, the stem cell has less issue with rejection than the bone marrow transplantation, which in everything, whenever you have bone marrow transplantation for a variety of reasons, you have rejection, etc. But there's been significant success, notable success that I should say. Yes, for a long time, sickle cell was underfunded, but now they're beginning to come up with some funding to really make it go at it. Okay.
I thought there was a cap on, I mean, there's been some controls by NIH.
Right.
On stem cell.
Right.
Because, again, it's still a brand new technology.
Right.
And I thought there was a cap on it.
Well, there's been some funding other places besides the NIH.
Okay.
Okay, because there is, if you go online, there's some sickle cell outfit that send me an email every month. I'm sure you
There's
guys.
no federal restrictions, is there?
No federal restriction. No federal restriction. No. It's been now proven as a successful method. Yes.
Okay.
Next question. Yeah.
I went to a conference,
Real loud.
I went to a sickle cell conference about maybe 4 years ago,
Mhm.
and they were speaking of using the HIV virus
I read a little bit about it. Again, I get this stuff every month. You probably get it as well and they're doing some stuff, but way behind time. They're nowhere near becoming successful at that. The only thing that is becoming quite successful is the stem cell transplantation. There's been tremendous headway being made in treatment as well. And, you know, you can't treat sickle cell disease. I mean, I used to have a lot of sicklers. It's a 24-hour job. And as I get older, I kind of don't get involved much anymore. I mean, I teach it and I write it because it's all day, all night. Because to keep a sickler alive, it's an all day, all night business. Because and then you send them home on Friday, and you're likely to readmit again on Monday, and I can't handle that. And in the general White Plains area, there's nobody here really doing any meaningful treatment for sicklers that I'm aware of. And I used to be the guy, but I can't handle at my age being up all night long taking care of folks anymore. So I still have a few. I have one 76-year-old lady. She's never been in the hospital once. No, never. I take care of her. She's 76. You know, most sicklers usually die when they're 50s. I have a 70s. In fact, she was in the office yesterday, 76. And I have not admitted this lady, not even once. Because well, it is care. I mean, I committed to her. She's got SC disease, and I'm 24/7. There's a lot that you have to do to take care of sickler besides just giving them pain medication. It's a total body commitment. You really have to know medicine inside out to properly provide care for somebody with sickle cell disease. It's a very complicated issue. You have to deal with the brain. You have to understand, when you have a sickle cell patient, the brain can get damaged. The heart, I didn't even bother to talk about the heart, the enlargement of the heart, ischemic disease of the heart because of the sickling, because of the plaque. I mean, there can be a young person, they're having cardiac arrhythmias, the heart becomes enlarged, they can go into heart failure because of all that secondary hemochromatosis, that the iron piles up in the heart. I mean, there's a lot going on. All you have to do is be a sickler, live long enough, you're gonna have some kidney problem. That's inevitable. Those are heavy duty stuff. And then I managed to keep this lady going because I'm sort of like, you know, what am I going to do with her? She's with me for 30 years, so I've been taking care of her. I haven't admitted her once. But knock on wood, God has been good to her and to me, so. Go ahead.
I have one last question.
Okay.
I don't want to dominate the.
That's okay, that's okay, go ahead.
But this is a non-biochemical question.
Okay.
The discoverer of diseases, usually the disease entity is usually named after the person who discovered
Discovered it, yeah.
Dr. Pollen, who worked really hard in bringing to the forefront sickle cell disease.
Right.
Why didn't we name sickle cell after Dr. Pollen?
Well, I don't know. I wasn't here. I was not even in medicine at that time. I can say to you that he got the Nobel Prize. He got the Nobel Prize. In fact, he got two Nobel Prizes, by the way. He's an activist, in case you didn't know. He got the peace, he got the Nobel Prize twice, one for medicine and one for the peace, yeah. And there is the Pauling Institute in California going full blast, even though he's passed away. So the reason, even the guy who first discovered it in in Chicago, they didn't name him after he did it. That's Dr. Herrick. They didn't either. I mean, he's the first one and his intern that discovered sickle cell disease in Chicago in 1910. They didn't name it after. I think, I don't know, I wasn't here. I mean, you know, I was not even born at that time. But of course I was born, but I was not in medicine. I was working in the factory at the time. Okay, any other question?
I have one.
You have one? Okay.
I'm just wondering if there is any possible way that an individual who has the trait doesn't know it.
Oh yeah, it happens all the time. That's what's unfortunate about it. It's unfortunate because in my practice, I'm still diagnosing sickle cell trait in 80-year-old men, 80-year-old women, 50-year-old men, because when they go to these doctors, you have to understand something. You cannot, and I'm saying this loud and clear, there's absolutely no way you could practice proper medicine on a person if you're not familiar with the culture and you're not sensitive to that. You just cannot. And I see it all the time. I see it all the time. All the time. Anybody who tells you that they can practice proper medicine, high-quality medicine, in someone whose culture they're not familiar with, they're not sensitive to, they're kidding you. They're not kidding me. As a matter of fact, that is so much so, now the powers to be, the AMA and others, have now given already 33 schools in this country grant to change the way they practice medicine so that they can include ethnic sensitivity and racial sensitivity. As a matter of fact, in the state of New Jersey, I think I'm correct, you can't get a license now unless you actually take a separate exam for racial sensitivity, ethnic, etc. You just cannot. The only thing that is the same is the anatomy. Everything else is different. And it's unfortunate, but this is what's going on. We don't have enough black doctors. We don't have enough Latino doctors. And then you have to understand, the older black physicians are retiring. The new ones, very few of them are getting in for racial reasons, so on and so forth. So you wind up having to go. I just read an article, and I was telling Mr. Bowman about it. I just read a white paper from the CDC, put a white paper out that was published in the Kaiser Health Journal that is sponsored by the Robert Hood Johnson thing in New Jersey, whereby they tell you, they interview more than 400 patients, many nurses, many doctors, and the summary is that racial discrimination is implicit in the practice of medicine. This is what the research found. I got it in my office. I wish I had brought it with me. And then, as a matter of fact, I think it's right here. Yeah, I gave it to him. He's got the paper. Pass it out. You read for yourself. I mean, when you read this, you would cry. What can you do but cry? Look at this. This is the paper. I just have it because I gave him a copy. Look at what it says. One lady had high blood pressure. The pressure was so high. And the doctor, the entire time she was in his office, in his examining room, he never made eye contact with her. So he gave her brand of medication. She refused to take it. Because she said, someone who has such lack of respect for me, I'm not taking the pill. So she rather die of a stroke rather than take the medication. And then there's a paragraph here. There's a paragraph here. You can't make this up. There's a paragraph here, and it says, this is the last paragraph of this thing here. Here's what it says. It says, okay, right here. And you can't make this up. This is, let me read it to you. It says, when you, what does it say? Where is the last paragraph here? When what it says is that when you go to the emergency room, you see nobody that looks like you. You know you don't belong. That's what it says right here. And it says, yeah, it's one of these things. The fact that we have large disparity along this line on income and race, it shows there is a lot ground to be covered. And when you read this paper, it makes you sick to your stomach. You either want to vomit. And this just came out. This just came out September 2nd. And we are, you know what the title of the Grand Round was at Montefiore 2 weeks ago? The title of Grand Round at Montefiore 2 weeks ago was the trauma of institutional racism. Let me repeat that. That was the title of the Grand Round at Montefiore Hospital 2 weeks ago. The trauma of institutional racism. We are in 2016. It hasn't gotten better. If anything, it's getting worse. Go ahead.
I just want to make a comment. I've known Dr. Alcena for 30 years. There are disease entities that are prevalent to African Americans. And Dr. Alcena has been stating for years and years and years that there are certain blood tests, such as that you would be able to see changes or differences based on your CBC or chemistries that one would do, doctors would do, and treat minorities or treat African Americans for. That hasn't been done.
No.
And Dr. Alcena has discovered a vitamin B12 deficiencies, which is prevalent in African Americans, and that so many of us are dying as a result, but undiscovered.
That's right.
Because when you go into the emergency room or the doctors routinely, they don't do a B12 test.
They don't.
So,
When you come to my office, my counter, right here, I was showing them my counter, there are about 36 or 50 different bottles, little flasks of B12, not just the flask, these are all young people, middle-aged people. There's at least 50, these are not people who I'm giving shot of B12 as a GP, these are all people that have been diagnosed with low B12 in my office. And then if you have low B12 and it's not treated, the symptoms after 5 years are not reversible. And what it does, it could paralyze you, you could have seizures. The myelin sheaths that covers all her nerves needs B12 to remain healthy. When your B12 is low, the myelin sheath become degenerated. You become degenerated as a matter of fact, the #1 cause of dementia in this country, especially in the elderly, has to do with low B12, okay? So, and then you have all these people going to doctors, they're getting all this Tagamet, they're getting all this omeprazole. They don't understand when you put somebody on omeprazole and Tagamet chronically, you're going to wind up with B12 deficiency because you need an acidic milieu to absorb the B12. But you just eliminate that milieu by giving them those pills. I'm not saying they don't need the pill, but if you give them this pill, for crying out loud, test the B12 as well. You can't be treating people for GERD with all this antacid. You don't realize what you're doing. What you're doing is that you need an acidic milieu to absorb B12. You cannot absorb it if you're creating an alkaline milieu. So therefore, you have an alkaline milieu. The person, you have to come to my office to see this counter that I have all this pile of these are young people. I give more B12 injection per week. I am about 2 dozen people getting B. This is all documented B12 deficiency. And I have two.
Lives, Dr. Alcena. You saved all these lives.
But that's true. But you have to understand, dementia and Alzheimer is not what we have in black folks. The vast majority of black folks who have so-called Alzheimer's have microvascular disease of the brain, because they have hypertension that wasn't treated. They develop multiple stroke syndrome. They don't have Alzheimer's. They may act, but that's not what they have. They have microvascular disease of the brain. In addition to that, they have low B12. Well, they have low B12. I'm finished telling you, if you have low B12, you don't treat it after 5 years, the results are not reversible. Yeah, they're not reversible, okay? So you have about 6 million folks with dementia, but you have 76 million people with hypertension. And then the vast majority of black folks, they're not taking the pill, they're not seeing the doctor. You have about 20 to 25, 26% of people are getting the blood pressure control. When blood pressure is not going, what do you think happening to your brain? You're creating multiple stroke syndrome. You wind up with dementia at age 4. I have young black people in my practice that are 45. They can't tell you what they eat for breakfast because nobody bothered to treat the blood pressure. That's the reason why the most common cause of congestive heart failure in young black men is not atherosclerotic disease, it's blood pressure that wasn't treated. That's right. And they're all dying from it. So, listen, all I can tell, I can only take care of those that I choose to take care of.
I just want to thank you because 20 years ago, I was supposed to die.
I'm sorry.
And you know that. And you treated me, and I'm here to say that today.
Well, I really appreciate it. I really appreciate it. And then this gentleman here was at one of the top hospitals in the country. In fact, I think he was running the hospital. I won't name the hospital. And then they did everything they're supposed to do for him. And then they missed the reason why he almost died. They actually missed it, flat out right. And for whatever reason, God sent him to me, and to this day, he's getting medication. The man almost died, okay? So they acutely did something for him, but they never bothered to find out what the problem was to begin with. And if he didn't come to me, or God didn't send him to me, he wouldn't know what hit him. He wouldn't know what he had. Yeah, to this day, he wouldn't know what he had. It's a true story. He wouldn't know what he had. So what I'm saying to you is the fact that I'm a patient advocate, yes. I'm a full-time patient advocate because too many bad medicine is being practiced, and I can't tolerate it. It is not necessary. And this is why right now you see what's going on. You see what is going on, the fact that you have all these people getting lousy medical care, getting terrible medical care because nobody bothered to do the test. In my office, I have a sheet and Dr. Davis will tell you, he used to help me in my office when he used to cover me. I have a sheet like that that has 6 columns, 6 columns, okay? And then when the patients come in, I do a complete, I gave you the one of the sheet, didn't I? Here you go. Here you go. This is what I have in my office. That's my entry sheet, okay? Pass it around. That's my entry sheet. When somebody comes to my office first, that's these different types of tests, and they're all necessary because I know who I'm dealing with. I know who I'm dealing with. I have somebody who I just diagnosed H. pylori in yesterday. H. pylori is a very bad bacteria you have in the stomach. And I just told that person this morning that she has H. pylori. I said, what is that? Person's been sick. There's no doctor in White Plains that individual I haven't seen. But nobody realized who the person was. She wasn't blonde with green eye. She came from a particular place. I know she had to have it. And I tested it. It's positive. And I saw the husband say, what? She's been having problems for 10 years. Well, nobody bothered. Nobody bothered to test her for it because they don't think, they don't know. They don't know about, you don't understand. I mean, you don't have to be a genius. I just checked H. pylori because I know where she came from. She's having stomach problem. So she probably has H. pylori.
Absolutely.
And that's exactly, and it came back positive, okay? Now, give me a break. All I did was to look at her. I know who I'm talking to. I know where she came from. And I mean, do you have to be a genius to figure that out? Not at all. That is why the AMA are just giving, the AMA, in case you didn't know, just giving 33 schools so far took the grant to change the way they teach interns and residents and medical students, to include ethnic sensitivity, racial sensitivity, because you have to understand, the method that's being used, you can't make this up, was started in 1900. Dr. Abraham Flexner was the chairman of the committee that set up the educational system that's being used right now, 1900.
Still same system.
The same system. And then all of us, and they use the Caucasian model to treat all of us. And then, let me finish before I give you have to understand, we have 7 billion people in the world. See why I can't live in the South? Because they'll kill me in a minute. The point is, you got 7 billion people, 4 billion live in Asia, 1.5 billion live in Africa, and the rest are telling those 5.5 billion people what to do.
Right.
4 billion live in Asia, 1.5 billion live in Africa, and the rest is, we force the jamming down our throat the model that we have to use. Give me a break.
Dr. Alcena?
Yeah.
With your knowledge of vitamin B12,
Right.
do you have any statistics, or do you treat any type of mental illness other than Alzheimer's with the vitamin A? Because I've heard that vitamin B would help conditions like bipolar and schizophrenia and so forth. Do you have any?
Well, let me tell you what's going on, okay? You need, all cells that grow in the human body require B12. Here's where the mistake is being made, okay? The mistake is being made because we learn in medical school, for you to be B12 deficient, you have to be anemic, your MCV has to be large red blood cells. So as soon as the genius sees, oh my goodness, the MCV is large, give me a break. What happened is that the minute you started becoming B12, you know how long it takes for it to become anemic from B12 deficiency? We have 5,000 microgram, an adult has 5,000 microgram B12 in his or her body, 5,000 microgram. We use 0.02 microgram per day. So it takes 10 years to become B12 deficient. You have to deplete the entire B12 store before you become anemic and before your red blood cell become enlarged. That's not how you diagnose B12 deficiency, because it goes like that. It's still up and it started going down. So in my office, I know who my people are. I know what kind of diet they have. I know what they cannot afford. So when I screen them, I'm not waiting for somebody. If you have pernicious anemia, yes, you're going to become anemic right away. But pernicious anemia is a small percentage of B12 deficiency. So you have to proactively test the patient for vitamin D. 90% or black folks have people of dark skin have low vitamin D, but low vitamin D will wipe you out. Low vitamin D not only gives you osteoporosis, but it raises your blood pressure. How do you go from low vitamin D to elevate? We already have problem with our blood pressure. Well, when you have low vitamin D, it overactivates the renin-angiotensin system, causes your blood pressure to go up. We already have a problem with blood pressure. So what chance do we have? You tell me. You have 90% of black folks have low vitamin D to begin with, and 1 out of every 2 black adults have high blood pressure. So this is a disaster. It is a disaster because I just finished telling you when your vitamin D is low, you have trouble controlling your blood pressure, even if I'm giving you medication. Because it overactivates the renin-angiotensin system that controls blood pressure to begin with, right? So therefore, when you have low vitamin D, forget about B12, that's important, but low vitamin D can cause depression. It causes ED in men. It causes infertility in women. It causes osteoporosis, and I can go on, okay? And then I just finished telling you, 70% of white folks have it, 90% of people with dark skin have it. So basically, the black community don't have a chance. You don't stand a chance, okay? You really don't. Go ahead, yeah.
Can you mention other major medical errors that non-black doctors may be making as a diagnosis on black patients?
Well, I mean, listen, I guess Mr. Bowman did tell you that I'm an M.A.C.P. I can speak as an M.A.C.P., meaning I'm the master of the profession, okay? I'm a senior doctor. So it's not criticism. I'm just simply, and I'm teaching as a professor in 2 medical schools. And I can tell you that one of the most outrageous things that's happening is the inability to learn how to treat blood pressure. White physicians don't know how to treat blood pressure because, since you asked, and I'll tell you, right? Since he asked me, can I tell him? Okay. We have.
Glad you asked.
There is a substance the kidney produces called renin, okay? Renin, okay? All non-Caucasian folks have low renin. So far, so good, right? Low renin. So for you to treat blood pressure, you got to pass through the renin-angiotensin system to treat it, right? Most white physicians, when you walk into the office, they will not give you a water pill to treat blood pressure. They will not give you thiazide water pill. It costs $7 per month for 30 pills. And yes, that's the #1 medication, okay, that you need. And you're not going to get it. And then, you're not only that you're not going to get it, the HMO don't even put it in the formulary. So therefore, you're going to wind up getting an ACE inhibitor, which is going to do you no good for you because we don't have any renin for the ACE inhibitor to block because you were born with low renin. I was born with all black folks. The only time a black person will have high renin, you have to have end-stage renal failure or you have to have renovascular hypertension, which is in total, those 2 entities represent 3% of people who have high blood pressure. And then 97%, therefore, of folks who are being treated improperly. I just finished telling you, barely 25% of folks with hypertension are getting proper treatment.
Hydrothiazides.
Okay? So therefore, when you have, and the medication, the sad part of it, it costs $7 for 30 pills for a month. So blood pressure, therefore, you're going to wind up with a beta blocker, which would cause you to be depressed, give you ED, and it's not doing no good. You can't use beta blocker as a monotherapy to treat blood pressure. It is senseless. It's ridiculous. And that's what you're going to get. So therefore, you have another medication, another family of medication, which is called angiotensin receptor blocker, which works in all ethnic groups. All ethnic groups. And it blocks the entire renin, angiotensin, aldosterone system, all of it. So why not that? Well, you ask me. Why? Because the HMOs think and realizes that the ACE is cheaper and they want you to have it. I've gotten into fight with them. Why are you giving the black and an Asian, all black people, all Asian people, all Latino people have low renin. They have what's called high volume hypertension. The volume in question is the volume of fluid they retain. Because wherever salt goes, so goes water, and the value will get expanded, you become hypertensive. And the reason why the reason why black has low renin is because way back in the mother country, Africa, before we got here, we needed to stay alive. So therefore, God decided we were going to retain salt in order to retain water, in order to survive in the ambient condition of Africa. That suppresses our renin, and we pass the gene through. That was a life-saving. Over here is a disease. Asian has low renin because of the diet. Over the centuries, they have a salty diet. I don't know if you ever ate that diet. It's salty, so it suppresses renin. That's it, okay? So therefore, nobody, by the way, nobody wants to be treated for hypertension the way black folks are treated because of racism. So the entire hypertension concept is being racialized. They're not going to take the pill because you're giving me the same medication, you're giving a black person out of your mind? Well, that's wrong. And by the way, this has been done. There's a study called the ASCOT study, Anglo-Scandinavian study. Involved hundreds of thousands of patients. Because over there in Europe, all these folks, they control the medical record, they control what they do. They did that. They give them beta blocker, they give them an ACE inhibitor, and they give another group the calcium channel blocker and the ARB, and they give them beta blocker. The group that get beta blocker die like crazy with heart attacks, strokes, and whatever. The group that get the ACE, the same thing. However, the group that get the water pill and the calcium channel blocker and the ARB did beautifully. The study, we could look it up online, the ASCOT study. So therefore, I'm not just making these things up. By the way, in case you did not know, and I'll let you know, I was one of those in 1992 who came up with the idea, another idea I came up with, that there had to be a gene that's located in the human kidney that causes us to become hypertensive. And sure enough, the study was done, the gene was discovered, and I get credit for that, a G protein receptor kinase type 4, okay? So I get credit for that too, okay? So that's one of the reasons why I became a master. So I think about it, and it turns out they went and did the study and they proved it. So therefore, now we know why you got hypertension. Every human being had G protein receptor kinase in the kidney, all of them, because the study was in a Japanese American, Caucasian American, and black from Kenya. They had actually specimen from the kidneys. They grind it up, they discovered that. And I came up with that idea. So now, ever since then, by the way, this is the only disease that is controlled by a committee in this country. That's the hypertension. In spite of that, they're not doing it right. There's no disease that gets treated more poorly in this country than hypertension.
But the pharmaceutical companies are making billions because they're not treating it properly and they're using.
I just in my little thing right here get today from the AMA website an email that's how ridiculous the amount of money, how ineffective the American healthcare system is. You could look it up and I just got it today. Today, I just got it today. How ineffective, the most expensive, the most ineffective way of treating people in this country. Okay? So all I can tell you, that's the reality here. Did I answer your question? All right.
Thank you,
Okay.
Dr. Alcena.
You're quite welcome. Now you see why I can't live in the South, right? Thank you so much.
I was basically feeling that thank you was not enough, so I'll say thank you very much. Before we adjourn back to some refreshments and hopefully spend some time with Dr. Alcena, let me make a couple of announcements, I guess. Come and copy the site for the article that was referenced. It's called "Attending to the Human Element is Key to Keeping Patients Healthy." It's 3 pages. You can get it tonight if you just copy that, rather than going back and try to email everybody, because I can't read everybody's writing anyway to send the emails. The other thing is that this is Sickle Cell Month, and the national meeting is going on as we speak in Baltimore. We have some friends in the community who are attending, and we'll be bringing back lots of information from that meeting. I should have that next week. I mentioned that to say, if you want us to forward information, keep you up to date, from the AANW on this issue. Just make sure I can read your email address, and I'll certainly do my best to keep you in the loop. And then finally, no, this is the penultimate statement, because I think that someone else has another statement to make. There is a bill winding through the New York Assembly and Senate called the the New York State Sickle Cell Treatment Act. There are, what do you call it, petitions circulating on that. If you go to change.org, you can find it, or you can look at it on my pad and see what it looks like. So come up, please, and get the information so that you can get the article. And again, thank you very much.
Oh, you're welcome.
Yeah, I had something to say. I met with Ms. Watson last year, Helena and myself, and we did a program, and it's a local person. We're trying, and I sat this summer at the African American Heritage Festival. We're trying to get people who have sickle cell or have relative sickle cell. We want to get a support group. And Ms. Watson graciously would give us room, but we can't get anybody to sign up for it. We really like this story. We've made a lot of effort together, but no takers. If you know somebody, please let Ms. Watson know so we can start this group. It's important because at one point we knew sickle cell people diagnosed with anything. But I was diagnosed with NEGRE at one time, and then someone else said, oh, you know what? But anyway, I went to their meetings, and many of the things, symptoms that sickness has, people who have NEGRE have the same symptoms. And they met, and nobody looked like me, and I said, why don't we have a group? Why don't we? Because I had a show at Union College, and I interviewed two young people at the time, maybe 6 years ago. They were 22 years old. Both were told the same thing I was told in 1956. You only can live until you're 16 years old. I have 4 children, and at Miss Victoria Hospital with my first child, that you will never, ever have a child. And I saw the doctor later, unfortunately, when my brother was dying. And I said, I'm so glad I tried my 2 because I have 4 children. So there's so much misinformation. This is Helena's daughter that's out there about syphilis. The one that you had before, I wanted to shoot myself while I was sitting there because they describe us as people who have all of these issues. And I always say, if you don't have anything positive to say to somebody about whatever they have, they cannot succeed. So I want people to sign up. My paper is out there, but I also have a write-up that Ms. Hayward did just for this meeting today.
Teresa, thank you very much.
Yeah.